Well, thank you so much. First of all, I want to thank Europe for having me here. I'm very excited listening to the meeting, and I want to thank first of all to the interpreters because I think they do a great job. It was very easy for me to listen to the whole conversation. So 5 minutes, 5 to 7 minutes, I decided no slides as after food, probably everybody is concentrating on digestion, and I have the hopefully whole concentration and not my slides. The topic is stigma, mental health, and it has been said a lot from the prior speakers. I'm excited by the standard of the meeting. So we had, it was referred to WHO, to the new diagnosis, ICD-11. It was related to not only substance-related addiction, not including also caffeine, but also to behavioral addiction. We had gambling spectrum mentioned disorder. We have covered EUDA. Lisbeth van Dam gave a very nice overview about the new mandate of the agency. So it's really an agency now where the people can also go in the individual countries to look how the monitoring is, because we rely on the data quality in order to define a problem. Well, and I heard several times the word stigma, and I heard human rights. So you also have included in the symposia the UN human rights treaties, and this is my bridge actually towards stigma. If you talk about patients with substance use disorder is part of mental health. So it's a psychiatric diagnosis, and the psychiatric diagnosis is included in the Convention on the Rights of Persons with Disabilities. Very often, not in this audience who is specialized, but in the general population, handicap is clearly related to somatic burden. Is it wheelchair accessible? But they don't have in their mind that a psychiatric disorder is also included in the Convention on the Rights of the Persons with Disabilities. And Slovakia and the Czech Republic ratified the convention, so you could address problems to your state if there appears to be a problem. And just the word stigma is created by society. And you feel stigma in many, many areas of substance use disorders. One is the accessibility. Very often I still find substance use treatment clinics not in the inner city, but somewhere out in rural areas. Even very often it's, first of all, I see the church, and then I look at what kind of treatment and how easy is it accessible. Persons with substance use disorder very often are not able to go out there, and if they're in these institutions or in these facilities, they don't have the freedom to go out and have fun. And also stigma is very openly, if you look in opioid maintenance, this is a very old thing we have now, more than 30 years in the majority of European countries. But still in many countries, you have an overregulation. People need to go to the pharmacy every day, and they have to line up. So it's very obvious for the others, that's the reason why these people are going to the pharmacy. So one aspect is just use the countries who ratified the Convention on the Rights of Persons with Disabilities to pinpoint if you feel that there is stigma related to substance use disorder. In my case, I have been running a substance use clinic at a university for many years. One of the first things when I took it over was, I don't want to have a ghetto on substance use depending patients and on the other one on the psychiatric patients. We have a waiting room where depression waits next to alcohol disorder, next to schizophrenia, and so on and so forth. So just try not to separate, they all have something in common. Very often, especially we do know it can be very difficult, you have homeless people, their hygiene might be neglected. But it's very important for us in the treatment to treat the whole psychiatric scope together and not isolate anybody. In addition, stigma is not only related to people with substance use disorder. Stigma is actually a significant aspect we have to face in the whole psychiatric disorder. And I give an example. 1920, a famous writer, 1920, stated, some of you might know Robert Musil, I'm not only having an underprivileged health, I'm having an underprivileged disorder. And this was a century ago. So we should not face this issue, and it was pointed out we are in a very safe environment in Slovakia, in the Czech Republic, and in Austria, of course, as well. In continuation, what has not been mentioned in this audience is the value, the aspect of comorbidity. We heard the high mortality rate related to polysubstance use disorder. We do know the high mortality relates to high comorbidity figures. And this is also one part, but addresses it very importantly, that substance use disorder is an integral part in the psychiatric spectrum. Because if you're not diagnosing the underlying psychiatric morbidity, you are never able to stabilize substance use disorder. And I just take as an example ADHD, attention deficit disorder. This is a disorder with 50% of the person with substance use disorder have this underlying psychiatric diagnosis. Very obvious clinically is the impulsivity, And a very wrong approach is to put these patients on benzodiazepines, because this is increased danger and risk for them to die. The adequate approach is to put them on stimulants, and very often people who are not educated and not experienced enough in diagnosing and treatment, they are really worried. But that's the standard of care. And this, for example, this is an example that having substance use disorder integrated in the psychiatric field is improving the situation for each individual suffering on this disorder. But this is, of course, an expensive way. And the society has to decide quality against quantity. And this is again a policy issue. I really like the models in Australia. They have specialized clinics, mental health clinics, where the whole psychiatric spectrum is together, and they work together with GPs. So you have a low accessibility, it's easy for the patients to go there, and you get the background of the psychiatric care and knowledge from specialized clinics. And one keyword is what we have to integrate, and what is really low threshold, is telemedicine, because psychiatrists are rare all over the European Union. So try and integrate telemedicine, and then you get a better care for the patients and for the society. Why? Substance use disorder is the fourth most expensive psychiatric disorder in the European Union. It costs about 300 billion a year. These are not the medication costs, these are the indirect costs. A lot of people are involved in criminal activity, a lot of people are ending up in jail. Another, even more expensive disorder is ADHD, also because of indirect costs, not being able to finish school, not being able to stay in jobs. And if you show these figures and you show the literature and show this to your politicians, they should be actually looking at figures and try to integrate this in the psychiatric spectrum and try to use telemedicine. COVID has taught us that's a tool, but in countries like mine, it's even paid by insurance, but it's very easy to use, and it's improving the mental health. And finally, talking about figures and money. Money is the issue, what politicians listen to. What is the addiction, the most expensive addiction for a society? Is food addiction. Many people talk about obesity. But if you listen clearly to the patients and to a clinical evaluation, the clinical features are totally related to features we know from people with alcohol dependence, from people with heroin dependence, and even the imaging pictures from binge eating disorder patients are equivalent to patients with substance use disorder. In the United States, since 1999, the body mass index of obesity increased from 1999, 30% to 42%. In my own country, 25% of adolescents have obesity. And I'm coming back to the comorbidity. If you diagnose the people, there is a high load on ADHD. Treat ADHD, their substance use, and this is referred to behavior substance, is gonna be treated. And my final message is, talking about comorbidity, we should not forget that in all the substance use disorder patients runs a gene. It has a high genetic heritability. And this is for me the importance towards general practitioners being involved in the substance use diagnosis and treatment, because it's low threshold, it's low stigma, and know the families. Thank you very much.